move on to talking about microfoam therapy. As you all know, the tumescent, the thermal tumescent treatment options have really been kind of at the forefront of treatment of superficial venous incompetence and venous hypertension. But as time has gone on, there have been further improvements in technology and different options. Tonight, I'll speak about microfoam, and Dr. Marson will speak about adhesive treatment. Now, physician-compounded foam has been around for a long time, and especially in Europe. However, there are some challenges with that, and part of the challenges being that when you get a complication can be fairly severe. As part of my disclosures relevant to this is I've done some speaking for both BTG and Covidien and given them a little bit of advice here and there. So we know superficial venous disease is not uncommon and it's not benign, causes a lot of problems, and we're all looking for healthy, strong, good-looking legs, not pain or discomfort, primarily because we are designed to move. Otherwise, we would have had roots, not feet. And we know about the low extremity pump, the venous anatomy. I think it's very, very important to have the foundation of sound understanding of pathophysiology and what's going wrong. So if you know normal, when you're on abnormal, you want to bring it back to the normal state. And it's very important even during treatment to kind of understand where the reflux is coming from, where the valvular incompetence is, and how we could treat it. We know that in the great saphenous and the long saphenous, which is relatively straight segments, it's easier to get a straight fiber up there and treat it. It's been around for a long time, but we know as the foundation, valvular incompetence of the venous system is what's causing venous hypertension, and which is what manifests in all the different symptoms we have. That's why we look for reflux. Obstruction can also cause reflux, especially compared to valvular incompetence, so it's extremely important to check that before we go anywhere. And as a foundational principle, I made it my practice to make sure that I'm always looking for the underlying source of the hypertension, whether that's telangiectasia all the way up to large varicosities, and understanding where exactly it's coming from. We treat with foam therapy. It's become very effective for CEEP6 all the way to CEEP1. And these patients are very complicated, hard to treat with lasers. You could definitely get at the source near a reflux with a laser or an RF, but it's very difficult to get into all the other branches. The other thing we do is we map out significantly the pathway of the venous hypertension, where exactly it's coming from. If there are any large perforators along the way, where it's because it may not always be at the saphenofemoral junction or the popliteal saphenous. Important to understand the CEEP classification. C1 being telangiectasias, as you saw in that picture, it's just the superficial part. C2 is varicose veins. C3 is when you get edema. 4 is when you start getting lipodermatosclerosis, hyperpigmentation. 5 is a healed ulcer, and 6 is an active ulcer. We see a lot of patients with wounds, and they're challenging patients who've had this problem for a long time. And what we found with foam therapy now is that's when they're getting relief and wounds are healing fairly quickly. So I'm going to focus a little more on C5 and 6, perhaps even 4, 5, and 6, rather than just a traditional saphenous thing. Now, treatment options are obvious. The goals, rather, are relief of the venous hypertension. You could do it conservative. You could do it with thermal or tumescent, and finally with foam therapy now. So the way we approach this is we first have a very detailed discussion with the patient so that they understand what's happening. We check the baseline. We want to establish their goals of treatment, whether that's healing a wound, relief of symptoms, whether the pain and swelling, or maybe cosmetic. We always start with conservative therapy first, and insurance companies are going to require that of you anyway. We spend a fair amount of time counseling the patient with all the different options, have very realistic expectations, cost issues come into play, getting insurance approval, and finally long-term follow-up. Now, as we get into talking about foam therapy, and especially microfoam therapy, you cannot do it well without compression therapy, graduated compression garments. Once you inject, basically it's causing a chemical ablation. Once you've done that, you got to keep the vein collapsed, and good compression therapy really becomes the mainstay of of treatment here. So gradual compression, very important, and it's after compression therapy that it doesn't work that we move on into microfoam. Now, the only real microfoam therapy available is polidocanol 1% that's manufactured by BCG, and it's available as Varicose. Physicians have done kind of home compounded. I've done the Tessari method for a long time. The challenge with that is, as I'll show you some slides later on, once you get with physician foam, if it gets into the D system, your chance of a complication is high. And if you have a patent foramen ovale and you land up with a stroke or vision disturbances, obviously that's extremely disturbing. Also, once you start treating it, you can get to a fairly high volume to kind of compress all the veins around it. And I'll show you a couple of cases that will help. See, here's a patient with varicose veins. He's very severe veins. He's had actually several years ago multiple phlebectomies done. This is recurrent, very complex, with multiple leaking perforators, etc. I'm going to show you a video of this case as we treated it. This is before, this is after the first session, and there's a segment in the lower leg. This is after the second session. And here is the what happened to the video. There we go. So in this case, what we had this gentleman, laser therapy, RF therapy was just close to impossible because he did not have a great asaphnis. It was already ablated many years ago. He had large incompetent perforators and had a lot of reflux from there and very large varicose veins. He had edema as well, but the varicose veins really bothered him. He stood all day. So in terms of the procedure, we get access. When you see supine, the veins kind of collapse down. But with ultrasound, we're able to get into the large branch, one lower down and one higher up. And in this case, we have mapped out the pathway of the vein already. Once I identified the vein that I was going to get into, in this case, I've used a large 18-gauge butterfly, but now if it's a longer segment, I will use a angiocat, get into it, get access. You can see here the large branch here. Because he's supine, that vein is not bulging out, but I can see where that is. I've gotten access into it, and you can see it's very tortuous. Then I elevate the leg. Elevation of the leg empties the vein out significantly, and then when we start to inject the foam into the microfoam, which is Varicose in this case, FDA approval is for maximum of 15 cc's at one time, but often you don't need that much. Once you've injected it with the ultrasound probe, we'll massage it all the way up. And at the point where there's a perforator, we'll actually compress the perforator with your finger to prevent it from going into the deep system. The interesting part of this is since there's very little nitrogen in the mixture, even if a little bit goes in, it doesn't really cause much problems, and it dissipates really quick. So at the point where we see the perforator going in deep, that's the point that I will compress it while I'm injecting. And after this, within a few seconds, you will see complete spasm of all these branches. Once these have all been in spasm and they've been completely down with the leg elevated, we'll actually put on a compression dressing and I make them wear their compression. So you can see this is the outcome 4 weeks later. That part has completely been ablated. It's shut down. It's technically a chemical ablation. He had another perf feeding this residual vein in the front going all the way down. We did something similar for that. And once we had that, another 4 weeks later, we'll see that that also has been completely resolved. There's a small branch further down here. We brought him back, and when we get insurance approvals, oftentimes we'll ask, depending on the complexity of the case, for multiple sessions. And oftentimes one canister that's available provided for them, we keep it for that patient itself. And after we identified this in a dependent position to kind of allow that to distend, I've gotten an 18-gauge angel cat, or rather a butterfly in there. Then again, by elevation of the leg, injected it, compressed it. So the protocol that I follow for the compression therapy really is that they make them wear them right then on the table with the leg elevated. Once the leg is elevated, and we put in a foam wedge along the pathway of the vein. That gives extra compression on the vein, but not on the whole leg. Once that is done, I advise the patient not to take it off for 2 to 3 days if they will do it at least 48 hours. I'll tell them, have a shower with it, dry it with a hairdryer, but the longer you wear it, the better. For the next 2 to 3 weeks, wear it as much long as possible, especially when you're standing. We've found that when that happens, their results are very good. We've had it where very extensive varicosities are resolved with just one treatment. Now, this is the second case, which is a complicated C6. The patient had a wound for a long time. He's been going to the wound center, has had a lot of different challenges along the way, and he was not healing. He had a large perforator with reflux. You can see all the lipodermatic sclerosis, the different staining, kind of the atrophy of the tissues right here, the champagne glass appearance, so to speak. And obviously the patient was just pretty distressed. And the wound care center had been treating him for weeks and months, and this was still not improving. As you saw in that insert, there were large branches filling in from a large perforator. I've identified that on the ultrasound as to this, and identified that that's where I'm going to go in. Again, it is not amenable to laser or RF ablation. It's so large, homemade foam also could cause problems, especially if it goes in and causes a DVT. So once I got access into one of those branches, in this case, I switched between 21 and 18. This is a 21 gauge, got into that branch. I've identified the site of the perforator, and which I've compressed right here, which I'll show you in an insert in the middle in a second. Then, depending on the size of the vessel and in around this, I'm collecting the Varithena foam out of the canister. It comes out almost like shaving cream, and it's very uniform micro bubbles. It has a few minutes worth of time to collect into the syringe and inject carefully. Since I don't want it to go into the deep circulation, I've identified the perforator. I've compressed that. And now I'm planning to inject in and around all those branches. And you can see once I've injected the foam, that foam is now into all the branches around the ulcer. The goal here is to replace the blood that's in the veins, and then I follow the foam up and keep pushing it up, so to speak, all the way till it gets to the source of the reflux, so to speak. And with the leg elevated after this, once we've gotten all the foam kind of pushing the blood out and the foam acting on the chemical wall, that part becomes really important. It's not a good idea to make the leg dependent to see whether that's working. You got to just trust it. Let the foam sit in there, just as this insert shows. Essentially, this foam, imagine shaving cream kind of consistency, replacing the blood, irritating the endothelium, kind of desiccating the endothelium, if you would, and shutting that down. I give it as much time as I can with the leg elevated. I cover all the branches around the feeding vessels. We've done close to 60 patients now with tremendous results that we've been able to get combined with wound therapy. So why was this even developed? And I think the issue really was with physician compounded foam. The challenges were there was less stability of the foam. In addition, that if once it got into the deep system, it could cause serious complications, especially given that the bubble sizes are large and there's a fair amount of nitrogen, which is room air. And you don't even want that one patient to have even a temporary TIA or something in your office or kill your practice. But when you look at the polydocanol foam that's created, it really will get into a very uniform pattern. Polidocanol has been around for a long time, and so that's nothing new with that. It's safe. It's in a volume. The key issue here is safety. And one of the issues is if you have a patent foramen ovale and you have embolus that goes up, you could land up with a significant stroke. It's well reported. With all the different studies that have been done, there have been no reports of PE or any such neurological symptoms. Diffusion-weighted MRI sequences have shown no such effects, even in patients with right to left shunt, which is the slide here showing that. It's well-established safety profile from multiple comprehensive clinical trials, and the complication rate is around 0.09% when you look at it. So no PEs. And when I say the complication rate, you can get some DVT. We've seen incidental asymptomatic DVT, and really it's a matter of watching that you don't get too much into the deep system. So as a non-thermal, non-tumescent option, it's a really good option. We've moved a significant part of our practice to this option. Obviously, you got to get approval from insurances for reimbursement. It's FDA approved, safe, effective. Patients seem to love it because they don't have the tumescent and the bruising afterwards. Well, thank you. I'll stop.